time to meet with you all, and I'm pleased to see you on Zoom, and I'm glad other people are still having challenges with Zoom just like I am after, despite 3 years of it. Seems like we should have gotten it by now. So I'm so pleased to meet with you today, and on behalf both of BC Women's Hospital and also on behalf of the BC Women's Foundation. So I had been asked to speak really around what we do at Women's Hospital in regards to mature women's services, and also how we're looking forward in terms of expanding those services and plans that we have going forward. So as Candice noted, I am Senior Medical Director. And really what that role entails actually is a lot around program development, identifying areas of need in the community, looking at programmatic goals, where we should be expanding our services, perhaps services that are no longer required or not met in the community. Ensuring that we're training our trainees well for aspects of care and women's health across the province, and also supporting research in those programs, as well as maintaining quality of care. So it's a very exciting job. I enjoy it very much, and have worked extensively with our foundation partners to really make some of this planning and projects reality. So we'll go through that, and I think we'll have ample opportunity for discussion and questions as well. So please feel free to use the chat and to think about your questions for along the way. So I will share screen. And again, please forgive any Zoom challenges I might have along the way. Okay. I am hoping that, can everybody see the Zoom screen? I've lost my ability there. Great. So one of the things that became apparent, I've been in this particular job, I've been in administration at Women's Hospital really since I finished my residency in 2002 in various areas, and have been in this particular position for about 10 years. So one of the things that I think we are definitely known for is delivering babies and providing obstetrical care, but we do a tremendous amount of work in other areas as well that I think is not as well known in the community. So one of the things that we identified, or I identified early on in my tenure, really was that we had some gaps in care and some potential to better meet needs, really on either end of our spectrum of population. So really the adolescent population transitioning out of pediatric care, and also the mature women population who are moving out of the reproductive age, but continue to have reproductive and health needs that are specific to women. Okay, advanced, okay, everybody can see it? Good, all right. So just in terms of what else we do at Women's, I don't know how familiar everybody is with our range of services. So obviously we have a well-established maternity service, but we do many, many other things, and most of those other things are under me. So I look after all of the ambulatory programs. So we actually have almost 60,000 ambulatory visits a year, both for our maternal population and our gynecologic population, serving more than 16,000 patients. We have had a really significant expansion of our surgical services here at Women's Hospital, focusing on gynecologic surgery and the recent introduction of our urogynecology partners to address pelvic floor and incontinence issues. And this really has been supported by the Diamond family, and we have developed a really state-of-the-art surgical center, the Leslie, Laurie, and Jill Diamond Gynecologic Surgical Suites. So that has been a really exciting development over the last really 5 years in terms of meeting women's needs, and also increasing OR capability at our partner hospitals in terms of transfer cases for cases that require a more higher level of care and a general hospital to support them. We also provide significant breast services. The Sadie Diamond Breast Center conducts 6,000 screening mammograms, over 2,000 diagnostic scans, and over 1,000 biopsies a year. So really, in terms of detection and diagnosis of breast cancer, we play a significant role. Obviously, we welcome more than 6,000 babies into the world every year in our maternity center. We also support trainees across the medical disciplines to increase their knowledge of women's health. That is in gynecology, that's in women's imaging, both obstetrical and gynecologic imaging, as well as breast imaging. That is in our surgical suites, and of course on our maternity service and in our NICU. And of course, we always attempt to integrate research with clinical care across the campus. So we really think of our work as a triad of education, research, and clinical care. And those things are entwined across what we do. And our foundation has been instrumental in bringing many of these things to fruition as we are challenged, obviously, with supporting our programs and also really making instrumental change. And sometimes we really need that initial funding to get something off of the ground and to demonstrate to the government both the utility and the feasibility of programs. So we have been very well supported by our foundation and have really achieved some significant things over the last 10 years in our ability to do that. So just some examples of things that we, in terms of being sort of poised to respond to emergencies, to new things that emerge, Women's Health Research Institute, which is our partner research institute here at Women's Hospital, we were able to launch the Canadian COVID-19 and Pregnancy Surveillance Project, really within months of the pandemic becoming an issue, which really was a trailblazing study that was launched with Catalyst funding, supported by our foundation, and was referenced across the country in terms of decision-making around vaccination policies around the world and care for pregnant women during COVID. So, and that really is based on our foundation of that important triad and our partnership with our foundation and our research institute. We also, based with our foundation, have had a fundamental improvement in our province's capacity for gynecologic surgery, as mentioned. And when I talked about Catalyst funding and pilot funding before, this started as a tiny project that was supported by our foundation, where we really looked at taking surgical cases out of the OR, more minor cases that had a transvaginal approach, and really could be done under sedation in a really efficient and patient-centered way. We were able to transfer thousands of cases, in particular cases that involve assessment of the uterine cavity for such things as postmenopausal bleeding, uterine fibroids or polyps, abnormal bleeding, out of the operating room and into procedure rooms. And we did this initially through a pilot study and then partnered with our foundation and the government on surgical renewal to lead the expansion and gradually increase our surgical capacity here from 1 OR to 4 ORs running every day to support gynae surgery for our patient population. We also are the first NICU. So our NICU is our neonatal intensive care unit, which supports really the sickest babies in the province, both who deliver in-house here at Women's Hospital and are also transported from across the province when additional levels of care. So we had been supported in a really innovative project and really meeting standard of care in terms of mother-baby rooming in. So there's really significant evidence around maintaining the mother-baby dyad together as a predictor of outcome for fetal well-being and also maternal mental health and recovery. Our new intermediate care nursery has all single room capacity for mother-baby dyads and actively involve the parents in the care of the child from birth. So that has been a huge and innovative project that has been supported by our foundation as well. So moving on to mature women. So mature women's health is something that we have been actively focusing on and working to expand our services in. And really, why do we think this matters? Well, we think it matters because all women matter, and women across the lifespan have needs that we aspire to meet at BC Women's Hospital. We also know that not every woman is going to get pregnant, but every woman will go through menopause inevitably. And that we actually will spend a significant portion of our lives and often a very productive portion of our lives in menopause. At least 1/3 of our lives is spent after cessation of menses. It also is a time during which women start to be at risk and develop more chronic disease. And due to longevity in women, which exceeds men, they're more likely to experience complications from those chronic diseases. We also know that this time is a particularly productive time for women. They often are at a really productive time in their careers. They're often in leadership positions. They have worked long and hard to reach where they are. And the symptoms associated with menopause, in particular vasomotor symptoms, abnormal bleeding, other health issues that arise, can be significantly disruptive to their work and life function, but in particular their work function. We also know that this is not a problem limited to women after the age of 45. Early menopause occurs for a variety of reasons. Women in their 20s and 30s experience menopause, either due to underlying genetic issues, due to cancer treatment, due to surgical removal of their ovaries, due to some sort of abnormality. So these are issues that can affect women at a very young age and will affect them throughout their entire life. We also know that up to a quarter of Canada's 19 million person labor force are actually going through the menopausal transition or are on menopause. So it has significant productivity and labor force impacts if women are excluded from the labor market or impaired in their work during that period of time. So what do we do now and what do we aspire to do? So I've been talking a lot about gynecologic surgical services because it really is one of my pride and joys. I provide clinical service there, and it also was a program that I had an extensive hand in developing. This is a really a center of excellence for basically MIS, which is minimally invasive surgery. So we pretty much do all minimally invasive surgery here. So we do laparoscopic hysterectomies, we do laparoscopic ovarian surgery, we do surgery for prolapse and incontinence. We do a lot of the more minor surgeries that I had talked about before in terms of addressing fibroids, polyps, irregular bleeding. We have developed a short stay unit, so the vast majority of our patients are discharged on the same day, or what we call a 23-hour stay, so discharged the next morning. It has been highly successful. We were able to respond very quickly during COVID. Many of you are probably aware of the challenges that were faced in surgical services. Because we, one, do a lot of cases without general anesthetic, which was a worry during COVID, and we don't require beds, and our beds are not used in a general hospital for COVID treatment, we were able to recover our COVID slowdown very quickly. In fact, we were back up and running almost to full capacity within a month of the directive from the government to reopen surgery. And we had actually been able to recover, meaning get our cases done that had been delayed or canceled by the end of the fiscal year, so within 12 months. And perhaps you're aware, but most other sites across the country have still not recovered from surgical slowdowns related to COVID. So we feel very privileged, and there were lots of things that contributed to that. But certainly having a standalone dedicated unit facilitated that for us. And there's also lots of good evidence that really focusing on one kind of surgery, perhaps people have heard about the Schuldeis hernia clinic or other types of clinics that really focus on one type of surgery and do it, what we would hope, to perfection, really improve outcomes and decrease complications. As talked about before, we do a large amount of breast screening and diagnosis. We're very excited that we're going to be introducing MRI as a second modality for screening and diagnosis for our patients within the next 12 months. We've had a little bit of COVID delay there in terms of our coil, but the demand for breast screening, as many people know, 1 in 8 women will develop breast cancer at some point in their life. So the demand and wait lists for breast screening are very high. It's a real challenge in the province, and we continue to try to expand our resources. We also will be post-COVID reigniting our fellowship in breast imaging, which is very exciting because there is a paucity of radiologists dedicated to breast screening expertise in this area. We also partner with our BC Cancer Agency partners and run a clinic that is around after breast cancer care. So this is a clinic for women who have completed their breast cancer initial treatment, whether that's chemotherapy, radiation, or surgery, but are on long-term hormonal management. These women face many challenges that are not always addressed well by their family doctors due to lack of familiarity, and in this day and age, due to lack of family doctors in general. And we have a NP-led clinic that helps women manage their medications, side effects from menopause, directs them to appropriate community resources around physiotherapy, density screening, wide variety of needs that they have in that 5 years after completion of therapy and transitioning back to primary care. We offer bone density screening. We have a healthy heart program where we collaborate with Dr. Sedlak, who runs the Diamond Women's Heart Center at VGH, in regards to really primary prevention and early secondary prevention of heart disease in women at risk. We have a population, and there's been emerging evidence that there are factors that we see in pregnancy, such as high blood pressure pregnancy and diabetes at pregnancy, that really are red flags and signal an increased risk of heart disease later in life. And we really are hoping to address that as early as possible to prevent chronic disease in women as they age. And we are continuing to build out our services. So one of the areas that has been identified as a, oops, sorry, one slide too fast, as a significant area of need, I would say, really is around complex menopause. And what we would think of as our mature women's health program. So complex menopause, there certainly is excellent care provided in the community by both family doctors, by general OBGYNs such as myself, by endocrinologists, various other practitioners, but there is a subgroup of women who experience very complex menopause, either due to other medical conditions, perhaps they are cancer survivors, perhaps they're breast cancer survivors, perhaps they have premature ovarian failure, perhaps they are not candidates for hormone replacement therapy, or perhaps they have failed hormone replacement therapy, where management of their symptoms and prevention of disease is really very challenging. This is an area that overall, I think, has been somewhat neglected, both in terms of education, in terms of research, and in terms of clinical care. So we know that currently there is one menopause fellowship in Canada that is situated in Toronto, and that really is across the country. There are very few academic dedicated menopause programs that then also have a clinical research program. So what we have found really, I think, moves the dial, both in terms of clinical care and advancement of care, is an academic-based program that also has an affiliated clinical research program that then trains our spectrum of practitioners and really elevates the level of care across the province over years, as well as contributes to knowledge translation. That means taking new knowledge that's generated through research and applying it to clinical care. So one of our aspirational goals that we are actively working on and very close to achieving is the establishment of an endowed chair in mature women's health who would establish just such a program at Women's Hospital in collaboration. And really the idea of an endowed chair or professorship is that this person is brought in partnership with the University of British Columbia. So they have really significant research deliverables, and they are supported to provide that combination of education, teaching, and research that we need to move things forward and becomes the catalyst around which the programs are built. This would be our first endowed professorship at BC Women's Hospital. These are really huge, very prestigious undertakings and really are in perpetuity. They are things that are established and expected to carry on to advance clinical care research and teaching across our province. So why does research matter? So research is really important. Without it, we really would not advance clinical care. We would not provide care in areas where we have not been able to in the past, and we would not be meeting patient needs. So I'm not sure if people have been reading in the media or if you guys have an interest in this, but for the first time in many, many years, a completely new medication for hot flashes has been just approved in the United States. So the drug is called Fezolinet. Bit of a mouthful there. It will come with a generic name as well. But this is a drug that has been in development for quite some time. It is a completely new agent that reflects a lot of research on our understanding of hot flashes or vasomotor symptoms. So over time, our understanding of why hot flashes happen has really become very in-depth and down to almost the neurotransmitter and molecular level. So we now understand that estrogen plays a role in our regulation of our body temperature, and that estrogen essentially suppresses one of the neurotransmitters that tells the brain when we're hot or not. So once estrogen is gone, that sort of regulatory mechanism malfunctions, and the brain then interprets or is sent the signal that it is overheating when the body temperature has actually not changed, which then triggers all of our heat release mechanisms, which then result in flushing, hot flashing, sweating, all of the symptoms women associate with hot flashes and night sweats, and is also why estrogen works. The challenge is that estrogen does not work for everybody. Not everybody can take estrogen. Estrogen is contraindicated in women with breast cancer. It's contraindicated in women who've had any sort of clot in the past. It's contraindicated in women who have a high risk for cardiovascular disease. There are some alternatives that have been trialed, primarily where there's been sort of a happy coincidence finding, which often happens with drugs, where patients are provided with a drug for another reason, and they happen to notice it decreases their hot flashes. So this is true of several of the antidepressants, which have been shown to have some reduction, not as good as estrogen, but some reduction in hot flashes, and also a medication called gabapentin and also Lyrica, which are medications primarily used for chronic pain that also have a modest reduction in hot flashes. Not as good as estrogen, but reasonable, all of which have their own side effects associated with. Now, that's not saying that this is a perfect drug, but this is a non-hormonal drug. It is a completely new class of drugs that target something called the CANDI receptors, like the name too, in the brain, and is thought to be appropriate for breast cancer or other patients who have hormones that are contraindicated. So without research, and really people have been waiting for this drug for a very, very long time with the wish to provide our patients better options. So it's very exciting. We're hoping it will come to Canada very soon. The one challenge with this drug right now is it is extremely expensive. As we often see with new drugs, the current cost estimated for the United States is $500 per month. So really quite expensive. So hopefully that will come down and we will see other drugs in this class. It's often the first one of a class of medications, and then there hopefully are new medications developed. But without research, we will never be able to develop these kinds of things. And I think it is really quite telling that there has not been a new medication for vasomotor symptoms approved specifically for that purpose, I think probably since the 1970s. So this is an area where there's been a significant lack of investment in research and clinical care. So the other thing that we're very, very interested in is something called knowledge translation, which I referenced a little while ago. So knowledge translation is, there's tons of research going out there all across the world. And how do we take that research when it becomes relevant and translate that into care of our patients? There seems to be a significant delay. Often you'll read about something in the paper or you might hear about a study, and it seems like forever before it actually gets to clinical care. Now, some of that is regulatory, some of that's drug approval, sometimes we need more research, lots of reasons. But some of it is that we really need to proactively be searching out that kind of information and then making sure that our clinical programs are actually keeping up with that, and that our clinicians are introducing new things and that we're supporting them to introduce new things. And this is a whole area of really research and innovation that is also very important to our Women's Health Research Institute, and also why it's so important to have those researchers that attach themselves to clinical programs. And we have that clinical, what we call a clinician scientist. So the clinician who actually sees face to face what problems patients are facing, knows the research, can then actually bring those research into clinics and then do outcome studies with their own patients, really on how is that knowledge translation working? How have we impacted patient care? Our WHRI has a lot of researchers, and close to 20% of them do fall into that category of clinician researcher. And that, again, is something we're hoping to emulate in our Mature Women's program. So this is around our endowed professorship in Mature Women's Health. This is a $6 million project. So, and again, it is in partnership with the UBC Foundation. So UBC is coming to the table, and the recruitment will be through our Department of Obstetrics and Gynecology. So they will have a research, the individual will have a research and clinical program based out of BC Women's Hospital, and Women's Hospital will come forward providing the operational support to the clinical program. We are very, very excited. It has been many years in the making to get to this point where we are really very close to realizing this and are actually starting to develop candidate lists and looking across the world, really, about appropriate candidates who might be an aspirational leader in this area. So very, very exciting, and more things to come as this develops. So really, who are we at Women's Hospital and the Foundation? We are one of a kind center dedicated to advancing the full spectrum of women's health. We are obviously stronger with our partners, our community partners, our patient partners, our research partners, our across the board. We improve the quality and potential of all women. And that really is my aspirational goal, is to improve the quality and life and care for women across the life spectrum. So I'm going to stop sharing because that's the end of the slideshow today. And I'm really happy to answer questions about programs, about women's health in general. Just see what you guys are interested in. I'm happy to be at your disposal.
There is a few questions. They said one is, can you see them, Dr. Rhone?
Yes, I can here. Okay. Yeah. So in terms of menopause and heart disease, so it is a complex relationship. So what we know is that in, and some of this is based on sort of data from the lab, and some of this is based on studies that were done in populations. What we know is that when a vessel does not have damage to it, so when it doesn't have atherosclerosis, when it's a clean vessel, basically when we're young, estrogen protects our vessels from cardiovascular disease. So estrogen is protective in the premenopausal woman, which is why heart disease develops later in women, and why generally we see heart disease sort of at a later age than in men, and where we start to see heart disease rise after menopause in women. Now, again, heart disease has many risk factors. So estrogen alone is not the only one. There's high blood pressure, there's lifestyle, there's genetics, there's lots of things. The other thing that we know is that once a woman has atherosclerosis or damage to her vessels, estrogen is a procoagulant, so it makes your blood stickier. So we see this in pregnancy, we see this with the birth control pill, we see it with hormone replacement therapy, that the number one risk is actually developing a clot in your leg called a deep venous thrombosis. That's a clot in one of the veins of your legs. Our baseline risk for that increases as we get older. So what we know is, in terms of the heart, if you have a plaque on your heart or partial obstruction on your heart, and I give you estrogen, I am more likely to precipitate a clot that causes a heart attack or a stroke in your brain. So this is the difference, and where some of the conflicting information about hormone replacement therapy and heart disease came from. When people probably recall the Women's Health Initiative trial, which was the very, very large trial looking at hormone replacement therapy. And when it came out, basically they said, estrogen is terrible, everybody come off of it, gives you heart attacks and strokes and all these things. So we sort of come back to the middle with that. And when we really looked in depth at that, what we found is that, and we saw this from some other studies as well, is that starting estrogen more than 10 years after menopause, or starting estrogen in a woman who we know has heart disease, that we're going to increase her risk of heart attack and stroke. Starting estrogen in a woman who is within 10 years of menopause or in the perimenopausal transition does not seem to increase those risks, again, because her vessels are probably not affected yet. But what we have not shown is that hormone replacement therapy is preventive for the development of heart disease. We would like to think that, but we don't have compelling evidence of that at this time. What we know is that it is not harmful if you start it within 10 years of menopause. Does that make sense?
Yeah.
I can't comment on heart disease and the COVID vaccine because that is not my area of specialty. To my knowledge, there is not. But again, this is not an area that I keep up in as extensively as, say, a cardiologist would. Exercise, yes, that is correct. Exercise does reduce menopausal symptoms. So interestingly, and this is something that I talk to my patients about a lot, is that the more that I read, the longer I have been in medicine. I like to think the smarter I get, I'm not sure. But I think that there are basic things that improve our health across the board and actually improve illness across the board. So it's not just our well-being, it actually is, has a positive or beneficial effect on, like things like diabetes, heart disease. And those things are actually quite basic. So exercising. So exercising really helps prevent or decrease the risk of pretty much every illness that you can think of across the board. Alzheimer's, dementia, heart disease, diabetes, cancer, menopausal symptoms, depression, you name it, exercise is good for you. Something we all need to be doing. The second one is diet. So obviously eating a diet that aligns with the Canadian food guidelines, is low in processed food. All of those things really benefit all illnesses and prevention of chronic disease. The third one is sleep. It's really interesting. Sleep is super important. So having regular sleep, getting adequate sleep helps diseases, all chronic diseases. It helps in menopause. And we know it's a challenge for women. So it's something we need to address for women. And the other one is social activity and brain engagement. So being active, being involved with our friends, being involved with other people, getting out, doing things like this, being interested in the world, learning new things, are very beneficial across the board. They're beneficial for our brains. They help prevent dementia. They make people feel better. They reduce really longevity. There was a very interesting study I read looking at exercise and prevention of heart disease. And what they found is there was actually a difference in the type of exercise you did. And the difference was how much social interaction you had with that exercise. So if you played tennis or you played on a team or you walked in a group, it was much more beneficial in terms of prevention of heart disease than, say, something you did all by yourself. You're a marathon runner. You ran all by yourself many hours a day. So you actually had more benefit in prevention of disease if you included the social aspect of exercise in it. So I talk to all my patients about that. It sounds easy. These are hard things. It's not, always easy to exercise every day or eat properly, but they probably are the things that we can do most to benefit ourselves across the board in terms of chronic prevention. And I think that's another thing about menopause. Women are very focused on the menopausal symptoms, and that is very, very true. It's very important we address them. I'm not minimizing that in any way. I'm a gynecologist. That's what I do. But I also think that we need to think about this menopausal transition is really the time where we need to start thinking about chronic disease prevention. Obviously, we need to think about that our whole lives, but particularly around the menopausal transition, because it is the time where we really need to be thinking about those lifestyle factors around screening for chronic disease and for cancer, about the preventive things that we can do to improve our health and quality of life going forward. So happy to hear anything else in chat, or if somebody.
I think there's a couple other questions in there. Okay.
Oh, sorry, I need to run it down again. Yeah. Okay. Yeah. So in terms of GP referral, we have not yet determined what the actual structure of the clinic would be. But I would say that at this time, all of our programs at Women's are really designed as tertiary level care. So we generally don't do self-referral. We usually require referral. And the idea is that we are providing a level of care that can't be accessed in the community. So really people who have exhausted general OBGYN and family practice in the community. And then we can escalate the level of care both by supporting primary care providers and specialists in the community, and also by providing care to those patients. Okay. I have a question. How much time does that cover? I'm not sure what that means. Postmenopausal bleeding. So postmenopausal bleeding is a really important issue. Sorry, Elaine, if you can clarify your second question, I can come back to that. Postmenopausal bleeding is a very important issue. So one of the increasing risks as women age is gynecologic cancers. And one of the common gynecologic cancers is endometrial cancer. So postmenopausal bleeding is a cardinal sign of endometrial cancer. 10% of women who present with bleeding after a year of no period will have precancer or cancer. So it should never be ignored, even if it is one day of spotting. At a minimum, it requires an ultrasound assessment and possible endometrial biopsy. Lots of times it's not cancer. It's a polyp, or it's just a bit of spotting, or it's nothing that needs to be worried about, but we do not want to miss that 10%. Endometrial cancer is highly curable, usually with hysterectomy alone, sometimes with additional therapy, but the vast majority is treated with hysterectomy alone. It tends to be low grade, meaning not very aggressive, and early when women pay attention to bleeding. So that's just something that you should tell your friends about, think about, and if there's any bleeding, report it to your care provider. At a minimum, have an ultrasound. Yes, exercise. Sorry, now I'm too low. So I had a question here on, okay, I have a couple here. I have one about a fibroid. So fibroids are benign muscle tumors. Half of women will have them by the age of 40. So they are very, very common. We generally treat them for management of symptoms. So symptoms that can be associated with fibroids are heavy bleeding, pressure symptoms, pain, discomfort, increasing abdominal girth, like you can see them. So in terms of treatment, in a postmenopausal women, they do tend to become less symptomatic and they tend to shrink, and obviously women stop bleeding. There are women after menopause who still have what we call bulk symptoms or mass symptoms just from the mass being there. Depending on the fibroid, yes, an advanced laparoscopic surgeon can remove them laparoscopically. We do usually up to what we think of as like a 20-week uterus laparoscopically. So yes, it's possible to remove them via minimally invasive approach, depending on your surgeon. Bladder changes, yes. So bladder changes, so pelvic floor and urogynecology and incontinence are a significant problem for mature women. There's compounding factors that lead to prolapse or incontinence issues as women age. So one is childbirth. Obviously, that's a significant factor. Actually, just being pregnant and carrying a baby impacts your pelvic floor. And then there's aging. So like all of our tissues, our pelvic floor becomes less strong as we get older. And then there's other lifestyle factors. So weight is a factor. If you have things like chronic constipation or chronic cough that put pressure on your pelvic floor all the time can contribute to it. So, but incontinence and prolapse is a significant issue in as women age. So there are a variety of both non-surgical and surgical options for managing prolapse. I think and incontinence. I think it's an area that women are becoming less willing to just live with. You know, it's not normal. It's something that can be addressed. It's something, again, that we should be talking about and seeking care for. Generally, care is provided sometimes through general OBGYN, also through subspecialists who are OBGYNs with additional training called urogynecologists. They're also pelvic floor physiotherapists. We are working with our partners. Urogynecology in Department of OB-GYN is established at St. Paul's. We have opened our ORs and now have our urogynecologists operating here, and are actually currently in discussions with our urology partners who are also interested in women's pelvic floor around what we could do in terms of expanded service at Women's Hospital as part of our mature women's portfolio. So again, hopefully more to come around that.
She didn't mention what exercise does. That's not.
Was somebody exercise and pelvic floor? Sorry, somebody came off mute.
Yeah.
Yes. So exercise has a significant component of helping with pelvic floor. So pelvic floor physiotherapists are actually quite helpful in terms of teaching women how to properly exercise the pelvic floor, and then often is a first approach that will suggest that for up to 6 months. There's actually some excellent online resources I can send around afterwards if people are interested, through the International Society of Urogynecology, as well as our own Dr. Jeffrey Rhone, that has some videos and various resources around patient education, around prolapse and incontinence, if that's something the group would be interested in, like me to circulate. I can do that. Yes? Okay. I'll do that afterwards. Yeah, so in terms of progression of urinary incontinence and other incontinence, so again, we would generally suggest elimination of all lifestyle factors that contribute. So again, that's if, treating constipation, treating a cough, avoiding chronic heavy lifting, weight loss, and pelvic floor exercise in terms of anything that strengthens your core and your pelvic floor. So there's dedicated pelvic floor exercises, like through a physiotherapist or program. Also, like Pilates and yoga are excellent for pelvic floor. All of those things where you sort of pull up your pelvic floor, pull in your abdomen. Strengthening your core is also strengthening your pelvic floor. So general fitness and core and pelvic floor exercises are all recommended, as well as elimination of factors that will exacerbate it. Do we have programs regarding study of arthritis? Currently, we do not. Women's has generally focused on reproductive and gynecologic health needs. Most of the rheumatologists, who are the ones who primarily focus on arthritis, are based out of Vancouver General Hospital. So we often will partner and are certainly happy to partner with specialists across the spectrum. But depends really where those specialists are located and where that service is best met. $6 million. So the $6 million has to do with an endowment. So how an endowment, this is, I think, in regards to the chair, or professorship. So how an endowment works, and there's quite a few endowed professorships or chairs in medicine in general. So how it works is that money is held in perpetuity, and that the money basically generates income to support that person forever, and then potentially can be passed on if that person were to retire. So that's the idea behind an endowed chair. There's different ways to recruit people. There's things called spend downs, where like you have a certain amount of money and you pay them and it's gone, then it's gone. The idea with this is a long-term investment that would carry on and would be hopefully in perpetuity. Okay. I have costochondritis on my fourth COVID shot last October. Yeah, unfortunately, again, this is an area that probably is outside my scope of expertise to advise on in terms of as an OBGYN. So I'm going to pass on that question. I'm sorry. Yeah, so there's a question about breast screening and Pap tests, okay? So Pap tests are recommended until the age of 69. And really that has to do with the incidence of cervical cancer. So cervical cancer is actually a disease primarily of young women. So cervical cancer has two peaks, one in women's actual 30s and one in women's 50s. And that's because most cervical cancer is related to exposure to the human papillomavirus. And this is another area that our foundation has been extensively involved in, is in the development and research around the HPV vaccine, which people may or may not have heard about, but now is part of the standard vaccination schedule for all children in the province and across the world. So cervical cancer is actually one of the cancers that we may be able to eliminate, or at least the 95% that is related to HPV with vaccination. So because it's related to a sexually transmitted virus, the risk as women age is much, much lower, and Pap smear screening is no longer considered necessary after the age of 69. Now, that doesn't mean that one wouldn't be done, say a woman presented with bleeding or needed a biopsy or a mass, but routine screening is not recommended because the incidence is so low after that. Breast screening as well, based on population. So breast screening is advised between the ages of 50 and 75, I want to say. Between 40 and 50, it is open to women and optional, same as women over the age of 75. So if you want it, the program will not decline, but the efficacy of it is not as high and incidence is a bit lower. The things women need to be more worried about as they age are the uterine cancer, which we talked about, for which there is no screening, but there is a early warning sign. And ovarian cancer, which is the one that is the real challenge. It is an uncommon cancer overall. About 1 in 70 women will develop ovarian cancer, but unfortunately there is no good screening or early detection. So diagnosis is based on symptoms. The symptoms would be pelvic discomfort, bloating, increasing abdominal girth. So a low threshold for seeing your family doctor and asking for an ultrasound if those symptoms occur. Again, an area where there is tremendous research going on, but unfortunately has not yet resulted in something that we can use clinically and reliably. Just moving down here. Dryness. Somebody's asking about vaginal dryness. Is that so? Again, very common and very treatable menopausal complaint. So without estrogen, the vaginal tissues, basically they change a lot. So they become thinner, they become less elastic, they don't lubricate as well, and they become more fragile. So women experience discomfort, dryness, pain with intercourse, pain with exams. So often the first approach to them is vaginal moisturizers. So there's a variety of vaginal moisturizers. Replens is probably the most common one. It is a non-hormonal over-the-counter product. It is basically hyaluronic acid based, and it sort of binds to the vaginal tissue and creates a sensation of moisture in the vagina. We always recommend sexual lubricants for women who are sexually active. Low-dose vaginal estrogen is very effective at treating these symptoms. It does take about a month to work. It is also considered very safe. So low-dose vaginal estrogen does not have the same risks as systemic estrogen. So basically, it's a tiny amount that's absorbed by the vaginal tissues. You don't have to take a progesterone to protect the uterus. We do not see any of the risk factors like increase in breast cancer, heart attack, stroke, any of those things with vaginal estrogens. So in women who want to use vaginal estrogens, they can use it indefinitely at appropriate doses to treat vaginal dryness or painful intercourse. I would say the one population that there's some reluctance by their oncologists to use it is in the breast cancer population. The serum studies that look at the amount of estrogen you get in your blood, it's like teeny, almost nothing. But that is usually done in consultation with the oncologist. The thing I warn my patients about is Health Canada labels every estrogen product exactly the same. So when you open the package and you read the insert, it's going to tell you all the bad things about estrogen, even though studies would show that vaginal estrogens do not carry any of those risks. So I always talk to my patients about that when I send them home. There also is a new product out, so this is exciting, within the last year, called Rhone. The generic name is Intrarosa. So this is DHEA. And what happens with DHEA is it is actually transformed on an intracellular level into estrogen. So the idea is that it minimizes any systemic exposure to estrogen and therefore any concern around, for instance, breast cancer patients. It has actually not been trialed, so the studies are limited. They don't have any serum data to show that. And there is a caution on it about breast cancer, but I think it is a certainly emerging and hopefully an opportunity where, again, similar to the new drugs for hot flashes, that we're seeing an increasing range of products and options that we can offer to women to treat this. Let me see here. A note about Vancouver Coastal Health and Oasis. Oh, explanation.